my name is Alexis Laux, and this is my case study for my clinical rotation 1814. My patient came in a couple weeks ago on Thursday, August 14th. She was 64 years old. She presented with right wrist pain, which had an obvious deformity and swelling. She came in alert, coherent, and oriented. When asked about her injury, she said that she was playing ping pong with her son when she took a misstep and fell. She tried to catch herself, and that resulted in her wrist injury. When she was asked about her pain, she said on a scale from 1 to 10, it was a 10. It was very severe. She could barely move her wrist. And there were no previous injuries at that site. The physician in the ER ordered a 3-view radiograph of her right wrist, which included a PA, oblique, and lateral. So we began by imaging her wrist in a PA centered to her mid-carpal region and collimated in. Then we moved to the oblique. We rotated her wrist laterally 45 degrees and centered again at the mid-carpal region. The lateral was a bit tough for her because she was in pain, but she was willing to cooperate and give it her best shot to put her wrist in a true lateral position. We centered to the mid-carpal region again, and these images were collimated close, leaving enough room for the right anatomical marker. So these images were taken using 60 kbp and 1.4 MAS, and this was on the hospital's portable x-ray machine. So some things to keep in mind when imaging a wrist. These projections demonstrate mid-metacarpals, the proximal metacarpals, distal radius, the ulna, joint spaces, tissue. So the radiologist took a look at these images and reported a comminuted distal radius fracture with intra-articular extension and dorsal angulation, an avulsion fracture of the ulnar styloid, and scaphoid lutency concerning for a fracture of the distal pole. He noted that the joint spaces were intact and there were no destruction or no destructive lesions. So based on these findings, the physician did order 3 additional x-rays after the ER doctor did a reduction on the right wrist. So again, we did these 3 images starting with a PA, an oblique, and a lateral. So in my images, you can see the lateral post-reduction is not superimposed. It's looking more like an oblique. And this is because it was difficult to visualize her rotation with the splint on, and it was difficult for her to move her arm in that position. Although the ER doctor was standing by watching as we were taking these images, and he said that these images were enough to conclude that the reduction was successful. So these images were sent to the radiologist again and assessed, and he noted improved anatomic alignment and a non-displaced scaphoid fracture. So throughout this study, the patient's physical state was monitored. We did continually check on her, like seeing if she was comfortable. Obviously she's in pain, but just continually seeing if we can, maybe take a break as needed. She tolerated this very well, and she is scheduled to follow up with orthopedics at a different facility. Something else to note, these images were taken on a 14 by 17 cassette in portrait orientation, and that's about it for this clinical case study. Thank you for listening.